Yeah, you are on there.
Oh, okay. Okay.
Hello. Hi, hello, Horst. How are you?
Hello. I'm fine because I'm a guest here in Marseille in this wonderful team with Marc Giovannini and his group, and I'm assisted by Fabrice and Françoise and Florence.
Florence.
Yes, Julie, and the chief is here. So everything is under control. And I don't know if you already get the history of this patient.
No, not yet. Not
Okay.
yet. If you can do a quick.
This is a patient with FAP, with a papillary adenoma, and we already checked the other sides of the duodenum. As you can see, when you now switch to the endoscopic image, you see multiple small adenomatous lesions. But if they are smaller than 1 centimeter in size, you can just follow the patient. And here, this is probably more than 1 centimeter, because you see the edematous and villous change of the papillary orifice, and so the bulging of the papillary roof. So that means this adenoma is probably not extending in the bile duct, but growing under the mucosa at the papillary roof, as you can see now. So the aim is, and this was discussed with the patient, to proceed to papillectomy. And I'm using the Pentax ED34 I10T2. So this is a deck scope with a disposable end cap with an integrated elevator, which is also disposable. So we should have a very small risk of transmission of MDROs. So, and we are in a difficult position because the papilla is located far in the second part of the duodenum. So I had to choose finally the long root position. Otherwise, I cannot approach it in an appropriate way. And in principle, you should exclude any risk of malignancy or the probability of malignancy. This is quite soft. There is no ulceration, and I can touch it, leave the snare closed. So it's also movable, as you can see. So no evidence of malignancy, no submucosal injection, because as a randomized controlled trial from Young in 2017 showed this increases the likelihood of an incomplete resection. This was a study with 50 patients, and the complete resection rate was 81 without injection versus 50 with injection. And the risk is, the reason is, when you inject, you can in principle not lift the papilla, which is connected to the ducts. So the papilla disappears then in the bulge. So, and I'm choosing an hexagonal snare, and we always try to grasp the tissue, push it slowly out from the upper part, as you can see. So now Florence is opening the snare slowly. Okay. And I try to get it around the lesion. And this, of course, the maneuverability is more difficult because of the long root position. So, and now I try to get the snare in the transversal. This may be a little bit, but this is the roof here. So very tangential to the surface. And now I ask you to close it. So it's now closed. And of course, we have a very experienced assistant. She closes tightly, which is important, because when you don't close it tightly, then there is too much coagulation. You have to squeeze the tissue, the fluids out of the tissue to have a small area for cutting. When it's too loose, then you have a lot of coagulation and it does not cut. This is fine, just wait. And I said we have the endo cut Q223. That means 3 means is a cutting interval. It's the alternation, cutting, coagulation, cutting, coagulation. When you want to cut very fast, then it's just 1. For example, the fastest is 1, 1, 1. This is more or less pure cutting. On the opposite, when you choose to interval 6, then it's cut, 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 more coagulation. For example, if you have a big stalk in the colon. So now the next step is everything is set. I just pull. So many endoscopists are nervous and always jiggling. This is not necessary. I just pull to avoid that the tip of the snare is pushing against the upper part of the wall and could finally even cause a perforation. So just pull and you will see probably it will cut 3 times. So I start. Exactly, 3 times. So
Very nice.
open the snare, open the snare. We will remove it. Oh yes, I didn't show the nice eye scan function,
No, it's,
which would make it
this is
even
fine, yeah.
easier. So close slowly a little bit. Okay, before we remove, I'll show you that we can even better see now the structure here. But we will finally check if you have completely removed it. So that means close a little bit tighter. So we pull it just in the open. We leave it here to save some time. We will remove it later on.
Horsi, do you have a different approach to papillectomy if it's a FAP patient or just a solitary adenoma of the papilla?
No, the technique of papillotomy remains the same. So, and you see now I use iScan 1, and you can see the small the small lesions around the papillary area. This can be left. These are separate small lesions which we can find everywhere. But the adenoma of the papillary itself has been removed on block fashion. We see already bile coming. This is iScan 2, and also to reconfirm that there is no remaining tissue, and you can appreciate the excellent resolution of this endoscope. So this is high def and different options to characterize lesions and to discriminate and also to determine the lateral extension. So now the next step, I don't know if you go to the other room or if you continue. The next step is we should place a pancreatic stent because this is part of the ESGE guidelines, although the evidence is not very high. It's mainly related to a small study from Harewood, I think in 2005, so many, many years ago. Only 19 patients were randomized, stent versus no stent after ampulectomy, and just showed a small difference. There are other retrospective series, multi-center series,
we wait to the
even higher rate of pancreatitis. So my recommendation is, if it's easy to cannulate the pancreas, then you should place a pancreatic stent, but don't spend a lot of time finally creating edema, make everything more difficult. This could even increase the risk. So where is the pancreatic orifice? And I try to come, this should be, this is now a Microtech sphincterotome for cannulation. Unfortunately, all movements are difficult here because of the long root position, but this is probably more directed to the bile duct. Maybe a glucagon.
Ah oui.
So careful probing.
And you don't leave a common bile duct stent usually.
No, no, this is not necessary. In this exceptional case, we can push out the wire a little bit to try to get the wire first in. Push it a little bit more out. Yeah, try to.
Oh,
Excellent. So it's
beautiful.
like in our institute, so nice to be assisted.
Ah oui.
Yeah, this is a pancreatic duct. Can you see fluoroscopy?
No, no, we can't.
Peut-on mettre les rayons, s'il vous plaît, sur la vision endoscopique?
Yes.
Now, can you see it now?
Yes, we can see it. Yes.
Okay. So the wire is far inside. It's undoubtedly the pancreatic duct. And I think there is no need now for injection. I would like to minimize the risk of pancreatitis as much as possible. So some do pancreatic sphincterotomy, but I think there is no indication. But we will just place a stent. And I ask Florence to push the wire forward. So
Do you give in this Horst, do you
Please?
give in these procedures non-steroidal suppository?
Yes, of course, in all ERCPs. So this is a nice hydrophilic wire, also from Microtech. You can appreciate the markers. Okay, this is also interesting. We have here short wire, so I have to lock the wire with the disposable elevator. And although we have here a short wire, I'm able to lock the wire, as you can see. No fluoroscopy because I just watched the markers. And in the meantime, the team got the stent ready. And I'm going to place, okay, a biodegradable stent, the ARCHIMEDES stent, because this is an excellent indication. And this stent is available in 3 different degradation options. So within 12 days, 20 days, or 11 weeks. And of course, we only need here the fast degradation within 11 days. And I will show you before I insert how it looks like. So hopefully the wire will. Okay, she has the wire. So pull a little bit on the wire. So it's biodegradable at 12 days. 90% of the stent will have been stopped, completely dissolved. And I will also show you now, freeze the image. You see, and within at approximately 20 days, 100% will have been resolved. And as you can see from the outer side, it has a helical shape. So it's not only draining through the stent, but also on the outside because of the helical shape. So even if it would block in the center, drainage is still provided. And this is, of course, excellent because the patient has not to be followed. And this is already the distal end of the stent. So we push it carefully. You see the flaps here. Pancreatic juice is coming. Can you see that?
Yes, we can.
Pancreatic juice.
Excellent.
Okay, remove. Yes, Florence, remove the wire. And we are finished.
Very, very nice demonstration. Thank you very much.
Thank you. Look,
so
the
we'll
pancreatic
go to...
juice coming.
Yes, yes. Very, very nice. A beautiful case. Thank you very much.
Thank you.
And we'll go to the other room to Professor Giovannini.